Dr. Dipanjana Datta. I am a genetic counselor. I'm also a state coordinator for West Bengal for Organization of Rare Disease India. And it gives me absolute pleasure to conduct our to conduct this webinar today. And I would introduce Dr. Rajiv Sinha sir. He's our pediatric nephrologist from ICH. He's the HOD of the unit of nephrology at ICH. And today we will be moderating a session on the topic of echoes from the basement membrane, which we will be discussing on Alport syndrome. And sir today will be introducing our speaker. Over to you, Dr. Rajiv.
Thank you. So I hope I'm audible, and without wasting much time, I would like to thank the Organization of Rare Disease of India for giving this important topic a place, and for hosting a series of talk on rare disease in kidney. The idea is that you can have rare disease in kidney also. And we had one talk, I think a couple of weeks back by Dr. Mordi, who talked on Bardet Biddle. Continuing this, we have got Dr. Asita Gupta with us today, and she is well known in the nephrogenetic circle. She has a special interest in genetics, and was one of the co-authors of the Alport recent guideline. She's currently working as a consultant in pediatric nephrology in Great Ormond Street Hospital, and she will be focusing on Alport syndrome, which has been aptly titled like echoes from the basement membrane. So Ashita, it is all yours, and you can start your session now.
Thank you, everybody, for welcoming me so warmly, and good afternoon to all of you. I'm hoping to discuss Alport syndrome and just highlight why we need to identify and diagnose this condition early, and just talk a little bit about how we manage our patients with Alport syndrome at the moment. I understand our audience is a mix of adult and pediatric nephrologists, so welcome, and genetic counselors, so welcome. I'm happy to take any questions at the end. I'd like to start with just a bit of a think about 4 really simple cases, something that you'd probably come across in the outpatient setting, not infrequently. The first is, what would you, and feel free, if you had the option of being able to write in the chat, and I would also encourage Professor Sinha and also Dipanjana to put their thoughts in as well, as how you would, in a sort of one line, what would your initial actions be if you had this case in your clinic? So first one, 7-year-old girl with persistent microscopic hematuria. You've taken a 3-generation family history, and there's no family history of kidney disease, and there's no proteinuria, no kidney dysfunction at all. What would you do with this patient? Would you carry on working up for a diagnosis? Would you discharge her? Would you carry on surveillance and wait? So what would you do with her? Second patient is 11-year-old girl with microscopic hematuria, but this girl has 2 to 3 cysts bilaterally on ultrasound scan. What would you pursue a genetic diagnosis of Alport syndrome with this patient, or would you think about cystic kidney disease? So this would be case number 2. So in your responses, if you put case 1 for the 7-year-old girl, case 2 for this one. Case 3 and 4 are 2 newborn babies with a family history of COL4A5 associated nephropathy. So, you know, in old school money, that would be called X-linked Alport syndrome. And they've had familial testing, and they have the same genetic change as their parent. How would you treat these 2 babies, and would you treat them differently? So there'll be case 3 and case 4. I'll give you just a minute or 2 to have a think about what you would do. We'll revisit the cases at the end, and please feel free to write in any way, whether it's in the notes or whether you've got a QA thing you can write on. So if we go into a little bit of setting the scene for Alport syndrome. So it's nearly 100 years ago now that Cecil Alport first described kidney failure with hearing loss, and thought about it as something that was linked, and first described the features of Alport syndrome. Then 50 years later, we found that there were associated eye signs with the condition. We then thought, well, actually, we discovered that there was a discovery that this was a problem with type 4 collagen in the glomerular basement membrane. It was a basement membrane condition. And then in the late 1990s, the first monogenic, the first gene, col4a4, was found, and one of the three currently known monogenic causes of Alport syndrome, which we thought of as col4a3, col4a4 in autosomal recessive inheritance pattern, and col4a5 an X-linked inheritance pattern. And throughout my medical training, I just thought of Alport syndrome as this triad of progressive nephritis, sensory neural deafness, and ocular signs. And then we have to talk about things at a sort of kind of cellular level. So at the cellular level, we know that the type 4 collagen is made up of 6 isoforms. So in the developing or fetal immature glomerular basement membrane, you get alpha 1, alpha 2 configuration of the collagen isoforms. And then as the basement membrane matures, you get the classic alpha 3, 4, 5 configuration, and that holds a crucial role in filtration at the glomerular filtration membrane. And then other basement membranes, such as in Barman's capsule, you'll see alpha 5, 5, 6. So that's the sort of isoforms that then go on to form the trimer, but the mature basement membrane is formed of the alpha 3, 4, 5 trimer network. And if the alpha 3, 4, 5 doesn't form properly during the capillary loop stage of the glomerular development, then the alpha 1, 1, 2 persists, so the orange and yellow trimer persists, and that is generally a little more weaker than the alpha 3, 4, 5. So the histopathological features, which many of us are familiar with, but maybe the genetic counselors may not be, but just to orientate you, the glomerular basement membrane, here depicted by this arrow, sits in between the epithelial cells and the podocytes. It forms an essential part of the glomerular filtration barrier. When you get the fetal or the early trimer replacing the alpha 3, 4, 5, then you get a sort of weaker glomerular basement membrane that's more amenable to destruction by sort of the proteases within the metalloproteinases that are within the cell. So then you get this classic electron microscopy sort of depicting a sort of splinting and splitting of the lamina densa in the glomerular basement membrane, and you can see thinning as well. We know over time that the electron microscopy findings range in severity from mild, like nothing. If you do your biopsy really early in a child, sometimes you don't see anything different on electron microscopy, but you have got a positive genetic diagnosis, and you may and you have got some microscopic hematuria right through to the severe glomerular basement abnormalities. And this seems to correlate with clinical manifestations, but it forms the first sort of argument for exploring therapeutic strategies to aim to preserve the integrity of the glomerular basement membrane and to make an early diagnosis before you start to see the glomerular basement membrane electron microscopic sort of changes, so that you can try and delay onset of renal failure. The extrarenal features, as I mentioned earlier, we were quite well taught when I was at medical school. So there was a high frequency sensory neural hearing loss. But you see here that in some patients, it can present in the first decade of life, although we normally counsel and say that it would be like a second decade of life and older that you'd start to see that hearing loss. And obviously, because being a rare disease, these early studies had really small numbers. The eye features are quite wide-ranging, but we tend to look for the anterior lenticonus and the fleck retinopathy. But you can see a wide range of things right through to retinal kind of holes that you can see on this optical coherence tomography image, and thinning of the retina. That's another image of the sort of macular or retinal fleck retinopathy. That can be in the periphery or central. Majority of these eye signs are things that will help to point us in the right direction in terms of diagnosis. They don't usually affect vision unless they affect the cornea. That happens in sort of rarer cases. And we know that there are other rarer features reported in the literature. So leiomyomatoses of the respiratory and GI tract, aortic aneurysms, the risk of post-transplant anti-GBM disease in a small proportion of patients, preeclampsia, and growth restriction with preterm delivery. So again, keeping to the pre-sort of genomic testing or genome testing type, era, in 2003, a mouse model of the condition was developed, and that led to the discovery that if you treated these mice with ramipril or ACE inhibition, that you could lengthen their life, and you would reduce proteinuria. And that was seen in the paper by Oliver Gross and team, that really nicely showed that with ACE inhibition, the dashed line here, you could delay age of onset of renal replacement therapy. And that was whether it was autosomal recessive or COL4A3/4 related Alport syndrome or X-linked Alport syndrome. So now it became really important to be able to start ACE inhibition early in patients, and the focus really went to picking these patients up early so they could start a disease-modifying therapy. And then next generation sequencing came along, which helped us to confirm diagnoses in those patients where we thought this is definitely Alport syndrome. So those patients that had that triad of nephritis, hearing involvement, classic eye signs, we could do that. We also found that it helped us to differentiate between autosomal recessive and X-linked type of Alport syndrome. So we knew who to test and who to offer cascade testing to. And we learned a bit more about how to counsel for patients. And then importantly, we realized that not everybody that we think has Alport syndrome actually genetically has that condition. And there were some features that were overlapping between what we thought were distinct genetic kidney diseases. And this in general tells you about the diagnostic usefulness of a genetic test or the diagnostic utility. And there was the landmark paper by Groupman and the Garavi group, which showed that if they try and classify the clinical diagnosis for patients, that's what's depicted in the colors, when they compared it to the molecular diagnoses, if you look at COL4A3, 4, 5 that correspond to Alport syndrome, actually a proportion of them were thought to be congenital or cystic kidney diseases in red. Some were also thought to be hypertensive kidney disease or unknown, not classified types of kidney disease. So a large proportion of the Alport syndrome was actually unknown CKD, but the majority did sort of show itself. And then if you see here that there were some patients who actually had an underlying diagnosis of UMOD that were thought to be glomerular and Alport as well. So there was a lot of overlap in phenotypic signs and symptoms. This just looks at a paper from a team in Spain, looking at sort of the glomerulopathy group here. there were some patients that actually had a complex inheritance pattern. It didn't look like it was clearly X-linked or autosomal recessive, and other diagnoses that then ended up being glomerulopathies were actually the interstitial kidney diseases. And there were also some cystic diseases that were also classified as glomerulopathies when you looked at the genetics. So there was clearly some overlap going on. So everybody was thinking, we only tested those patients with microscopic hematuria and those where their parents had microscopic hematuria or family history of kidney disease and or the hearing or eye signs. But have we caught all of our patients with Alport syndrome? So when they started to apply whole exome sequencing in broader groups of patients with other signs, like those with FSGS on kidney biopsy, they found that Col4A3, 4, 5 did make up some of those patients, but there were also other molecular diagnoses. And patients with FSGS or steroid-resistant nephrotic syndrome, we should look for Alport syndrome in that group. And that would be helpful because we can stop using immunosuppression where it's not needed. More recently, there have been case reports of patients with Alport syndrome actually having cysts on kidney ultrasound scans. So there have been case reports of it. And also looking at the 100,000 genome data, the Gale group in London have done more like genome-wide association studies, and they've found that the collagen genes, especially Col4A3, is actually a really significant gene that comes up quite a lot when you're looking into cystic kidney disease. They've sort of postulated that even though it comes up here, it still may be an Alport sort of disease, a disease that causes Alport syndrome, but it seems that the clinical manifestation of cysts is definitely associated within this phenotype, which is really interesting. So the genetics of Alport syndrome, just to say broadly, now we recognize that it's not just X-linked or autosomal recessive, but there is this intermediate group, which some people termed as sort of dominant Alport syndrome. And we know that there's now something like a spectrum of conditions where there's risk of kidney failure and the more significant risk associated with Alport syndrome. But we're now starting to try and measure what are the other extrarenal signs and symptoms associated with this group of patients where they only carry one variant in Col4A3 and Col4A4. There's also a big drive in raising the awareness of Alport syndrome in women as Col4A5 associated Alport syndrome, and being able to sort of appreciate that due to the random exon activation process, that actually some women may end up developing signs and symptoms associated with X-linked inheritance of this condition. And whereas before we used to label this as being a carrier of the condition, we try and avoid that term now, and we try and use X-linked Alport affecting a woman, and we try and offer some form of surveillance going forward. So for these women, just sort of retrospective data looks like kidney failure, they can be affected by kidney failure, and approximately 15 to 30% are affected by this by the age of 60. They can have ocular signs and they can have hearing loss, but because it happens at that kind of age where this may be age-related hearing loss, sometimes this can be missed. And then Judy Savage has described that the eye signs that are normally well measured and seen in men affected with X-linked Alport syndrome are also seen in women at a later stage, and we think at a lower proportion. But we need to do a few more prospective studies to know this for sure. So the revised definition of Alport syndrome, I think everybody knew that this needed to take place. The earlier study I showed you with ACE inhibition in those affected with X-linked Alport syndrome and autosomal recessive Alport syndrome also identified that there was a risk of to patients who were heterozygous for COL4A3 or COL4A4 variants. So then the sort of diagnosis or the definition changed to any genetic variant that interferes with normal synthesis and deposition and function of collagen type 4 within the alpha 345 network of basement membranes. And now I'm seeing a lot more sort of use of the term Alport spectrum. And that's really helpful for all of us that are clinically active, because it helps us to know that our patient has a genetic change. Where do they sit in terms of clinical features? Are they at the mild end or the severe end? And you can use things like your genetic diagnosis, or if you're lucky, some functional information. You can use your variant. So now we know that if you have a missense variant, that's really different to a protein truncating and nonsense variant. And we can say with some assurance that the ones that have truncating or nonsense variants, we can expect them to be at the severe end. So it's worth doing the genetic testing to also be able to prognosticate. And then we also know that whether you're heterozygous or whether you carry two variants in COL4A3 and 4 will influence or help you to predict how severe the phenotype's going to be, as well as whether you're male or female with a COL4A5 variant. So I should cover the general diagnostic approach when talking about Alport syndrome. And obviously the clinical assessment's really key. You do want to try and elicit family history, and that's always been part of the requirement for proceeding to genomic testing. Definitely in the UK, it's been part of the test criteria. So if you've got hematuria in the proband and in first degree family members, that would allow you to proceed with genomic testing. You want to do a clinical examination, including blood pressure. You want to rule out any acquired or inflammatory causes for your condition. And you want to try and elicit the eye signs that are really sensitive at helping you to pick up the diagnosis and have been shown to be positive predictors of sort of clinching the diagnosis. Imaging is part of the guidelines as well. But now we know that genetic testing is the sort of gold standard, and there's less emphasis on doing a biopsy. So we try and use a genomics first or genetics first approach. And the consensus guidelines that I assisted with in 2022, these were the sort of indications for genetic testing at that time. So if you've got persistent hematuria for more than 6 months, persistent proteinuria, or steroid-resistant nephrotic syndrome or biopsy-proven FSGS. If you see the usual sort of eye signs, you're able to elicit those, but they're not always there if you're assessing a child really early on in life. Again, that same thing applies to hearing loss. So sometimes you can't really pick that up in children, but you should look for it. And if you find it, you should definitely proceed to genetic testing. We know that the proportion of familial IgA glomerulonephritis has collagen 4 cause, so they should be tested. If you've done a kidney biopsy and you see abnormal GBM together with hematuria, you should proceed. And obviously kidney failure with or without hematuria and family history or kidney impairment, you should do that. And then there was also this realization that we should include, we should not preclude, or we shouldn't exclude anyone that has renal cysts on their ultrasound scan, because now that we've seen that even if you have cysts there, you may still have a molecular diagnosis of COL4A3, 4, 5 associated Alport syndrome. Sorry, and then just to say that over the last 24 months, within the UK generally, just because we've had really tight testing criteria, so we couldn't proceed to testing unless we'd kind of elicited things like a family history. So we had this group of patients where we had hematuria but no positive family history, and we couldn't really proceed with genetic testing for them. And if they didn't have proteinuria, we weren't doing kidney biopsies. And what was really interesting was Rachel Lennon's group in Manchester looked back through their like 10 years of their cohort of patients with microscopic hematuria, and they found that half of those patients that ended up getting a molecular diagnosis did not have a family history of microscopic hematuria. So the parents were testing negative. They didn't have any family history of kidney failure. So that was really interesting. And I think that will drive a change in allowing us to now go on to test those patients that don't have a positive family history. The other really nice thing about this study was it just echoed what we've been told by previous studies, but is that presence of proteinuria helps you, as well as the hematuria, is a positive predictor of having a genetic diagnosis of Alport syndrome. Sorry, this isn't, the boxes aren't aligning very well, but if you're having to use a ACE or an ARB, I suppose that alludes to whether there's proteinuria. That's also a positive predictor. Eye involvement is a positive predictor. If there's family history of microscopic hematuria or kidney failure, that's a positive predictor. So you can help to kind of pick those things out when you're seeing your patients through your clinical examination and history. And this is a nice study also by the showing the phenotypic features within the Indian cohort by the team at AIMS. And they sort of just showed the same thing as Rachel Lennon's group, in that the association of Col4A5 variants with clinical features, a proportion would have some proteinuria, a proportion of them would be on ACE or an ARB. They didn't pick up as much hearing loss in females as they did in males. Eye signs were only picked up in 20%. So this is what I mean about relying on hearing and eye signs. Sometimes you may not get that there. The family history of microscopic hematuria was there in a higher proportion in boys than girls, but it wasn't always there. So I don't know how useful it is to gatekeep genetic testing based on family history. So getting to the end of the slides now, so we can go back to our cases in a moment, but I still think there's a role for kidney biopsy, and this is an algorithm, and the references below if you wanted to look up when you would think about doing a biopsy. But I think if you had persistent glomerular hematuria with normal C3 and C4, patients got sort of clinical features that would be suggestive of Alport syndrome, you would go for genetic testing. And hopefully you'd get your pathogen, etc. That would be one pathway. However, if you don't have any clear family history, you don't get a positive diagnosis from genetic testing, so you've got a VUS that you don't really know where you stand. If the patient has got renal impairment, or you need a genetic diagnosis, or you need some kind of diagnosis to continue with surveillance, then you may want to pursue a kidney biopsy. But in general, the proposed indications for biopsy are if the diagnosis is not clear at all and there's overlap with something else, if there's rapidly progressive glomerulonephritis or accelerated decline in kidney function, you should definitely do it. And if there are other family members that have got different presentations and again causing diagnostic uncertainty, there would still be a role for kidney biopsy. But if you see here, in terms of management, we still are using ACE inhibition as our primary way to manage Alport syndrome. So we want to make a diagnosis early, and I wanted to just put in a little bit about clinical usefulness of results, just because this is my area of interest, really. The genetic diagnosis will help in many ways, and it's important to record them for your patients. they may help in stopping unnecessary treatments like immunosuppression that carries their own risk. You may be able to offer, right now there's sort of renoprotective therapy in terms of RAS blockade, but there are lots of trials looking into more specific targeted treatments, and that will come into play in the near future. You want to ensure that your genetic diagnosis goes hand in hand with the way that you're offering surveillance for families. So there might be other family members that may or may not want to take up testing, but they may need surveillance for their hearing and or vision and or kidneys. It's important that we record if we avoid kidney biopsy as well as if we progress to it. And then obviously this diagnosis does impact transplant planning. As I was mentioning, in the past, we used to often accept donors who we used to sort of label as carriers for Alport syndrome. And now we know that it's not a completely risk-free thing for them to do, that this does carry probably a little bit higher risk of renal failure than we initially thought, and for hypertension. And that, as I was showing you earlier, depending on the type of variant that you have, they may have more than just a minor risk of these things happening. So they just need a lot of counselling about that. It doesn't mean that you absolutely can't take donors from this pool of patients, but I think it's something that, I don't know, in the UK we're counselling heavily, and we tend not to go down that road. But it's not I think otherwise, in other settings, it depends on the context of why you need the transplant and whether there are other options of renal replacement therapy. In some situations, there aren't. The main goal of being able to offer genetic testing and a genetic diagnosis is so that we can prognosticate, we can put things in place to support the family as a whole, and we can allow them to have more children with in a more informed way through counselling, and if they wish to have more active access to prenatal or pre-implantation genetic testing to avoid having affected children, then this is something that at this point, as nephrologists and as genetic counsellors working in this area, we should feel confident in approaching. And as I mentioned, cascade testing is influenced by the type of genetic change that you have, and who you offer testing to will be influenced by that too. Research and registry involvement of patients can also go through this sort of clinical utility spectrum process, and just ensuring that we remember to refer patient to support groups where able. So this is my sort of last slide before we go back to the cases, but it's just a nice summary of therapeutic options for pediatrics, ACE inhibition is the standard of care, and we don't really have anything else that we can use, especially in the UK. I know for adults, you're lucky you get to use the SGLT2 inhibitors, and they're showing a really the trial data has been really promising for patients with Alport syndrome and albumin or proteinuria, and delay of renal failure through that mechanism. And then there are lots of different trials looking at the effectiveness of so the miRNA approach. I think the animal studies using this approach were really positive, and I think the sort of clinical studies so far have been equivocal. The Fiona trial looking at finerenone, we're awaiting the output from that. The endothelin receptor antagonists are also being trialled at the moment. And then hand in hand with that, there's the exon skipping type treatment, for which there's a small trial as well. So the future is going to change in terms of options for treatment. But for pediatrics, we're just hoping for the SGLT2 inhibitors. I don't know what you're doing in India with regard to using those, but we're not using them at the moment. So just to end, I wondered what people would do with these cases, and perhaps I'll let Dipanjana and Professor Sinha sort of come back to these cases, but if you wish. But for the 7-year-old girl with persistent microscopic hematuria, if you had said to me 5 years ago, what would I do? Then I wouldn't have been able to proceed with genetic testing. Actually, even 2 or 3 years ago, I wouldn't have been able to. I would not have opted to do a kidney biopsy without proteinuria, and we would have ended up just offering surveillance. I would have tried to look for eye signs and any hearing impairment to support the diagnosis, but otherwise that's what we would have done. Now we can offer genetic testing, and doing that can then allow you to test family members as well and offer screening and support to them. You can also offer genetic counselling in the absence of genetic results as well, so that's still an option. The 11-year-old girl with microscopic hematuria and 2 to 3 cysts bilaterally, with her we would have also done the same things, the clinical evaluation, ruled out any other causes, but also progressed to genetic testing. And the strategy I would have used is we normally do sort of whole exome sequencing, but we would have applied the sort of glomerular or hematuria panel first, and then if that was negative, then opened it up to a cystic kidney disease one. A newborn baby boy with familial col4A5 variants. This is a big change. So if you pick this kind of thing up, you would want to test the baby to see if they have any hematuria. And if they do have hematuria, then around the age of 1, or around that kind of time, you would start ACE inhibition before they develop proteinuria. If it was a baby girl, you would do the same thing. You would look for hematuria, but with a baby girl, you would not start ACE inhibition until they had signs of proteinuria. And those were the sort of really key important changes in the sort of new guidance that we're currently following. So just to end, I wanted to offer my thanks to the Organisation of Rare Diseases for inviting me today, and Dipanjana Datta and Professor Sinha for supporting, and I'd open up to any questions.
Thank you so much, ma'am.
Thank
you so much for the wonderful lecture. The session is now open for questions. I believe Professor Rajiv Sinha will take this forward. So,
yeah. Again, thank you from my side also for an excellent, simple, straight cut presentation. And as you all know that Alport is becoming very, very important, and at the same time, I think it is also becoming quite confusing also with all this new evidence coming up of the early start of ACE inhibitors preventing. And in India, we are a bit excited about it because then of the new development, because then ACE inhibitor is something cheaper. Most of the time, the new development, we don't get excited because they are very costly for us, and often they are not available. But ACE is something which we can start right away. So that is one of the reason that why I am very much interested in this. And I think most of us are also interested. Dr. Dipanjana can have a look at the chat box for any question, but till then, I was going to ask you one question, a couple of questions I had in mind. One was like a very practical case that we are seeing at the moment. This one is a child who presented with, I will just discuss 2 cases very quickly. One is a child who in fact, this child was surprisingly being seen in UK only, in the Basildon area. They are living in Basildon, and for the last 1 year was being investigated for recurrent UTI. But never had a significant pus cells, but always had a bit of a microscopic hematuria, always. And when we investigated for the proteinuria, that was also significant. So a protein creatinine ratio was 0.5. So a persistent microscopic hematuria and a protein creatinine ratio of 0.5. Absolutely no family history. We have investigated the mother and the father, their generation, as well as the grandfather. Nobody has any urine RE abnormality, and there's no family history otherwise also. So in this situation, with a microscopic image and complement, etc., normal, would you go for genetic, or would you go for biopsy? Second scenario, again, both of this scenario is something like which we are dealing at the moment. Second scenario is a child who has recurrent episode of gross hematuria precipitated by exercise. In fact, we have tried this like urine before, and then then we have asked him to exercise, and he produces red urine. No hemoglobinuria. It is hematuria. No hemoglobinuria. So again, in this situation, would you go for a biopsy or would you go for a genetics? I mean, can Alport also Alport also can have gross hematuria on exercise? So these two questions to start.
Nice questions, thank you. So the first patient, how old is she? Or...
Is a boy. He is about I think 3 years old, around 3 years old.
Okay, so I think that this is only based on my experience. It's not based on it's not in the guidance or anything like that. But based on my experience, I think if you did I think it's worth looking into whether this patient has got like a Colfray 345 associated nephropathy. I know that if you went for biopsy at that age, the chance of you seeing a change, even if he did have a significant nephropathy, like the chance of you actually physically seeing that on biopsy would be quite low, actually. And that's just based on like my clinical experience, is that if you biopsy early, especially before they've got proteinuria, well, we don't often yield a diagnosis at that stage. And I don't think it's particularly helpful, but genetic.
This child has a proteinuria, a protein creatinine ratio of about 0.4. So that is like a bit significant only.
Yeah, in that case you could, but generally we would just avoid doing that and do genetics first, so you know what you're dealing with. And you know whether you know the inheritance patterns and you know a bit more detail about it. So unless you have a decline in kidney function, or like I said in the presentation, unless you've got something that is atypical, not quite right, like you do in this case, because you've got some overlap because he's got recurrent UTIs, I suppose. But I would still go for genetics first in this case and reserve a biopsy for later on if you need it, if it's
Sure.
genetic.
So this recurrent UTI, I think never had a recurrent. It was a microscopic hematuria which was labeled by the GP as a recurrent UTI.
Okay. In that case, I would definitely just go for genetics first. It's the lower risk option. And then I would only offer a biopsy if genetics were negative, because you've got proteinuria and you're worried about a glomerular cause. I would do a biopsy. And then your second case is really interesting, isn't it? There are reported cases of exercise-induced hematuria and exercise-induced AKI as well. I mean, I think maybe adults might see them a bit more in their practice than we do. But I recently went to one of the London Tubular Centre talks, and they were talking about that same thing. I don't know if exercise-induced macroscopic hematuria can be associated with like the sort of collagenopathies, but I do know that anything that vaguely resembles an IgA, so I think that there's a role for genetics and there's potentially a role for biopsy as well. There's a role for both. I would do genetics first as but
So actually,
So
even I
in both of the cases, then you'd go for a genetics first, right?
yeah.
So I actually seen the second patient with sir is saying, right? So this patient, the way the urine has progressed, like, and it was a very gradual progression, and then it was like the last few weeks was a massive progression. So even I felt it was less likely to be genetic and it was more likely to be immunological, because in the sense of the way he was presenting, and he had nothing else, like there was no other symptoms, and just because of the exercise. So he had a sports day. So if I was taking the history, so he had a sports day which precipitated the event, and then he had a very mild fever, and then nothing, and then gradually these things were progressing. So don't you feel that just doing genetics, like, because reports in India come after a month, so just genetics might reduce us missing the IgA nephropathy, like this was what I was thinking at the back of my mind, like because the kidney biopsy will probably come sooner, and in India, we don't get a report in 2-3 days. We get a report in a month. So am I losing more days to this child?
Yeah, this
In UK, they get reports much better, right? The genetic test, not even within months.
no, it's not within a month. It's like 3 to 6 months. And sometimes you can get an urgent one within
Yeah.
14 days if you're going to do something invasive to a patient or they're getting ready for kidney transplant.
That is different. Yeah, that is different.
What I would say in this situation is exercise-induced hematuria is a benign condition, and like call4A3, 4, 5 associated nephropathy is definitely not benign. And the issue is I think I personally would find it really difficult not to look for it. Because like I said earlier, if you make the diagnosis early, you can offer some disease-modifying therapies to delay onset of renal failure. So I think in this case, that's why I would do genetics. Is that I hope I demonstrated.
So that's what I also advise. I advise for genetic, keeping in mind that, as you said, that exercise-induced hematuria per se is a benign condition.
Yeah.
I think, Dr. Dipanjana, if you can mute, it is Dr. Dipanjana. I think there is a similar question in the Q&A also, which is a hot topic. We are only discussing, like which should be first, genetic or kidney biopsy.
Yeah.
So do you want to say anything on it? Genetic or kidney biopsy?
Well, it's definitely going to be genetic. That's all I've been saying the whole half. I definitely think that I only reserve kidney biopsy for those specific indications. So if your diagnosis doesn't fit at all, but there's some suggestion of Alport syndrome, but it's not classic of it, then you should think about it. And if you've got problems with function and everything's declining rapidly, then you would definitely need to do a biopsy to see where you're at, for a role for whether there's a role for immunosuppression or anything like that, or any other treatment. So I think if there's an issue
I
with
would
diabetes,
totally agree. This has also changed my practice also. Like, and I would again like you to comment on this. Like, for previously, just as you said, just for microscopic hematuria, we would just wait and wait.
yeah.
We would do a biopsy only if the parents are very worried. You try to dissuade them a lot, but if they're persisting beyond 1-2 years, then we do a biopsy, or if there's significant proteinuria. But now with evidence coming up with Alport, if you start early, even in the absence of proteinuria, their kidney outcome is better. So
Yeah, I think we've
I
kind of lost.
think yeah, Yasser logged off. Now he joined back. He has joined back.
While Professor Sinha joins back, I was just going to add that the other thing that's changed my practice is that I was always trained as a pediatric nephrologist to look after you would look after the family, but you'd never have sort of reproductive discussions about family planning, really. And I was never trained to do that. And I did that later on in my training. But now I use the genetic results, in especially in parents that are of they're of reproductive age, then we actively talk about whether they want to have more children and the risks to them as well. So a lot of these mothers that had the col4A5 associated genetic changes, they didn't have any follow-up. And if they developed renal impairment later on in life, then they were under kidney follow-up. And I don't even know now if all of those patients are under any follow-up, but I do ensure that they are at least seen by a kidney specialist at the point of diagnosing their child, and they have a full phenotyping done for hearing and eye signs and things like that. Yeah, that's changed my practice.
I think, yeah, I think that's a important message that we as a pediatric nephrologist also need to percolate it. The early diagnosis of Alport can make some difference, because there is this in general community, there is this concept that anyway it is a genetic disease, you don't have any specific treatment. What will happen even if you diagnose earlier? You are
Yeah.
not going to treat it. But now with this evidence coming up that in favor of ACE inhibitors, so this should be percolated. I had one more question, if I am permitted. It was like we do see children with frank nephrotic syndrome, steroid resistant, who are having call for variant, and that too pathogenic. Now in this, and we have biopsied some of them, obviously, like we have biopsied most of them because we biopsy all the sRNAs, and many of them don't have any changes in the basement membrane. Their EM is reported normal, but still they have a likely pathogenic or a pathogenic variant. In this sort of a situation, is it like what you said, that it is too early to have a change in the basement membrane? But then I can't understand that they are having a nephrotic range proteinuria, but without a change in the basement membrane. Is that possible? Like, have you seen something like that?
Yeah, I bet the clinical chemist, the clinical biologist in the laboratories, they must get this a little bit more, and they manage to report something that's relevant to the clinical context, in the end. But there is a lot of this, and we don't fully understand what's going on really in that context. We don't know whether it's something that is to do with a different like disease process that we're not able to pick up. We don't know whether it's the area that we biopsy, or whether it's the variant interpretation that's not quite right, or there's lots of questions, and things change, and all of this changes according to the ethnicity of the patient as well. So I think overall there's lots of questions still, and it's definitely about the heterozygotes, definitely. And it's not completely fully clear, and it's also not clear if some of these patients have an ApoL1 variant that not everybody looks for when they have these genetic tests applied. So we don't know actually for a lot of these things. Sadly, we don't know yet. But what I think is really fantastic is that looking through the literature now, there's more, the representation of sort of Asian countries is definitely a lot more over the last 5 years. And overall, that will help with some of the variant interpretation and phenotyping. So I think this is an area that needs a lot of sort of development, and a lot more Indian studies, to really, because we see
So,
that
Asita, in your clinical experience, did you have any children who had this sort of a features, like frank
yeah.
nephrotic syndrome, steroid resistant, col4 variant, pathogenic or likely pathogenic, but electron microscopy normal?
Yes, I have had a collection of patients like this, and then there was a couple where they had advanced kidney disease, so the biopsy couldn't tell us anything histopathologically. It just all looked like end stage kidney disease, so I didn't know. And then they had one, I think they had col4a3 or col4a4 pathogenic variant, and I didn't know, and we still don't know how to label it really, because it was a childhood onset, like severe disease, because even that level of urea is really severe. So we've put them, so all these patients, I tend to cohort them as highly clinically suspicious of a genetic condition, with either with where the genetic results don't match up with what you're seeing, or with a negative or VUS. And then I go back to those ones every like 2 to 3 years. I'll go back and just look at, would that diagnosis have changed. And the labs in the UK, a lot of conditions are moving towards whole genome sequencing now. So they will reanalyze the data for you, or they'll answer specific things after a given time interval. And the time interval is to allow for new publications and more knowledge about variant interpretation.
Dipanjana, any question? We are almost at the time.
So we have no further questions, and thank you, Dr. Ashita. Thank you, sir. Professor
Thank you
Rajesh
very
Sinha,
much,
sir.
Asita
Thank you,
and
ORDI.
Dipanjana and the ORDI. Thank you. Thank you, Dipanjana.
Thank
Yes.
you,
Thank you,
Prasanna,
Asita,
sir.
Thanks, everybody.
for joining despite your busy schedule. Bye.
Yes. Thank you, Ashita ma'am. We have been working for a bit because of ICH and Professor Rajesh Sinha, and it was a great pleasure to host you in ORDI. And thank you, Prasanna sir, Madan sir, Praveen sir, for helping us coordinate this. And thank you, viewers, whoever have joined. If there are any further questions, you can send it to ORDI, and we can definitely get this, to Dr. Ashita, and we can give you an email reply of it in case you did not ask a question today. So we'll come back again the next day. We continue our nephrogenetic session, and our next speaker would be Dr. Alison Ma, and she would be speaking on atypical Hus, something which is a puzzle, and we expect you to again join us and support us as you have. It's same time, 4 p.m. Next Saturday. See you all. Thank you.